Assalamu alaikum dear students, welcome to your channel The Anatomy Canvas. In today's class of embryology of the GIT, we are going to discuss the development of the liver and the gallbladder and describe the development of the pancreas. So first of all, we will do the cells of origin of the liver. There are three sources from which liver basically arises. These are the endoderm of the foregut, the septum transversum, and the vitelline and the umbilical veins. So first of all, we will do the liver development. The primordium appears in middle of the third week as an outgrowth of endoderm at the distal end of the foregut. So in this diagram, you can see this is the distal end of the foregut from which the liver primordium is appearing. This liver primordium consists of rapidly proliferating cells that penetrate into the septum transversum. So this pink color area shows the septum transversum, which is present, and this liver bud grows into the septum transversum. The connection between hepatic bud and foregut becomes narrow, forming the bile duct. So this is the connection. As liver grows, this connection narrows down and it will form the bile duct. The small outgrowth appears from the bile duct and it will form the gallbladder. So in this diagram, you can see this is a small outgrowth which is appearing from the common bile duct, and it will form later on the cystic duct and the gallbladder. The liver cords differentiate into liver cells and lining of the biliary ducts. In this diagram, you can see these are the liver cords which are developing into the septum transversum, and these liver cords are derived from the endoderm of the foregut, and the septum transversum mesoderm will form the blood cells, the Kupffer cells, and connective tissue cells. So these are the two sources. Here I am telling you about these two sources which are forming the liver cells. The septum transversum, which is present between liver and the foregut. In this diagram, you can see this is the septum transversum which will forming the ventral mesentery, and it is forming between the liver and the foregut, and liver bud divides the septum transversum into two. This green color area shows the septum transversum. So the area of the septum transversum which is present between the liver and anterior abdominal wall will form the falciform ligament, and the area which is present between the developing foregut and the liver will form the lesser omentum. Together, both of these are collectively called the ventral mesentery. So mesoderm on surface of the liver then differentiate into visceral mesoderm, except on its cranial aspect, in which liver will remain in contact with septum transversum. This area of the septum transversum will form the central tendon of the diaphragm, and here the liver will be in direct contact to the diaphragm, will form the bare area of the liver. This is the third source. The paired vitelline and the paired umbilical veins which are present, they are forming the hepatic sinusoids. So there are anastomotic channels between the vitelline veins as well as the umbilical veins. Later on, the modification taking place, and a shunt is formed which is called ductus venosus. This shunt carries most of the oxygenated blood from the left umbilical vein directly to the heart and bypassing the liver, and the other veins usually disappear, and these two sources, the vitelline and the umbilical, will form the sinusoids of the liver cells. At about 6 weeks, blood cells, stem cells immigrate into liver from the yolk cells, and hematopoiesis begins. This is a very important function of the liver in intrauterine life, because in intrauterine life most of the hematopoiesis or hemopoiesis takes place in the liver cells, while near the birth, at the time of the delivery, bone marrow take this function, and then the size of the liver also reduces, and this function is taken over by the bone marrow. So this is another diagram showing you the hepatic diverticulum, which is started to develop from the distal part of the foregut, and this is growing into the septum transversum along with an outgrowth which will form the gallbladder. Here you can see the gallbladder which is present along with cystic duct, and this is the common bile duct, and this is the area of the liver which is growing. And in this diagram, you can see both the right and the left lobe of the liver are forming. This is the common bile duct, the cystic duct, and the gallbladder which is forming over here. So what about the molecular regulation of the liver development? This is very important. Although all of the endoderm of the GIT has the ability to develop into the liver primordium, but this activity to develop into liver cells is suppressed by different factors, and these factors are the notochord, this ectoderm over which is overlying, and also the non-cardiac mesoderm. So what are the factors which actually suppress these factors and which activate this endoderm to become the liver cards are present in the cardiac mesoderm. These are the fibroblast growth factor 2 which are released from the cardiac mesoderm, and these factors have an inductive effect on the endoderm of the distal part of the foregut where the liver bud will form and which will later on differentiate into the hepatic cards. Also another factor which is also very important is bone morphogenetic protein 4 which is released from the septum transversum. This bone morphogenetic protein upregulates the expression of the FGF4 into the distal part of the foregut, and these both two factors collectively acting over here will induce the endoderm to form the liver bud. So these are the factors which are responsible for molecular regulation of the liver development. So now we are going to discuss the clinical correlates in development of the liver and the gallbladder. The first is accessory hepatic duct and duplication of the gallbladder. This may occur, but sometimes patient do not be symptomatic. Most important is the extrahepatic biliary atresia. In this case, there is the stenosis of the bile duct. And this is a fatal condition, although it is a correctable condition. Most of the cases it is correctable, but in such cases when it is not correctable, then it can be fatal, and only help we can give to the patient is the liver transplant. Another very rare anomaly is intrahepatic biliary atresia. This can also occur in cases of the development of the intrahepatic biliary passages which are developing from the endoderm of the foregut. So these are the different clinical correlates which are associated with the development of the liver and gallbladder. Now we will discuss the development of the pancreas. Basically, pancreas appear as the two buds. One is the ventral pancreatic bud and other is the dorsal pancreatic bud in 4th week of development, and both of these arise from the dorsal part of the caudal part of the foregut. The ventral pancreatic bud moves dorsally and to the right side along with movement of the duodenum and comes to lie below and behind the dorsal pancreatic duct. So in this diagram you can see this one is the ventral pancreatic duct and it comes to lie below and behind the dorsal pancreatic duct, and these two buds then fuses, and after fusion they will form the proper structure of the pancreas. So the ventral pancreatic bud will contribute to uncinate process and part of the head of the pancreas, and the dorsal pancreatic bud will form remaining part of the pancreas. Similarly, the pancreatic ducts, the distal part of the pancreatic duct and all of the ventral pancreatic duct will form the main pancreatic duct, and this pancreatic duct will open into the duodenum at major duodenal papilla. So in this diagram you can see this is the distal part of the pancreatic duct and this is all of the ventral pancreatic duct which is opening into the major duodenum at major duodenal papilla. Another diagram showing you the movement of the ventral and the dorsal pancreatic bud. So these are the direction of the movements of the ventral pancreatic bud, and it comes to lie over here the below and behind the dorsal bud, and then these two fuses with each other and form the common pancreatic duct. Common pancreatic duct also called the duct of Santorini. So this is again the different ducts system. Another diagram to show the development of the ventral and dorsal pancreatic bud which are present over here. This is the uncinate process which is formed by the ventral pancreatic duct. Sometimes accessory pancreatic duct may be present, and this accessory pancreatic duct is present because of the persistence of proximal part of the dorsal pancreatic duct. Usually distal part of the dorsal pancreatic duct persist and it will contribute to the main pancreatic duct and its proximal part disappears. But when it is present, it will form the accessory pancreatic duct, and this accessory pancreatic duct will open into the duodenum at the level of the minor duodenal papilla. So in this diagram again you can see movement of the ventral pancreatic duct, which comes to low below and behind the dorsal pancreatic bud. So main pancreatic duct formed by the distal part of the dorsal pancreatic duct, and entire ventral pancreatic ducts open at major duodenal papilla. You can see over here, this is the main pancreatic duct and this one is the accessory pancreatic duct, which opens at minor duodenal papilla and it develops from the proximal part of the dorsal pancreatic duct. The islets of Langerhans develops from the parenchymatous tissue and insulin secretion starts at 5th month of development. So different factors which are involved in the formation of the pancreas. First, two main important factors are the fibroblast growth factor 2 and activin. Basically, the sonic hedgehog protein is present and it is expressed throughout the GI endoderm. So to form the tissue which is responsible for development of the pancreas, first we have to suppress the sonic hedgehog gene, and this suppression is caused by FGF2 and activin. These two genes suppress sonic hedgehog gene. As a result of suppression of sonic hedgehog gene, the endoderm will differentiate into the structure which will form the pancreas. Another factors which are responsible for the endocrine portion development are the PAX4 and PAX-C. Those cells which are having receptors for both PAX4 and PAX-C will develop into the beta cells, gamma cells and delta cells, and those cells having only PAX6 receptors will develop into alpha cells and will form the glucagon. So these are the different factors which are responsible for molecular regulation of the pancreas. This is the anomaly which is related to the development of the pancreas. So basically the ventral pancreatic bud appear as two parts, and both of these move behind the duodenum and come to lie beneath and dorsal to the dorsal pancreatic bud. But in some cases this does not occur, and one part moves behind the duodenum and other parts moves in opposite direction, and in such way an annular pancreas is formed which will constrict the duodenum and which will lead to the duodenal stenosis. So this annular pancreas are a ring of the pancreatic tissue which will be present and encircles the duodenum. So this is the diagram. You can see the two pancreatic bud from the ventral pancreatic, and these two moves in opposite direction, one having the normal route and other in opposite direction, and moves anteriorly and comes to lie behind the dorsal and in front of the dorsal, and these two form a ring like structure which will form the annular pancreas. So here I complete my today's class, dear student. These are references: the Langman Medical Embryology, The Developing Human by Keith Elmore, and Gray's Anatomy by the Susan Standrings, the 40th edition. Thank you all for your attention, and inshallah in the next class we will do the midgut formation. Till then, Allah Hafiz.